Hello everyone. In this lecture we'll start with the very important and a very vast chapter, that is antimicrobials. We'll try to keep it very crisp and I will highlight the important points. You can get the mind maps, you can DM me, and these mind maps I will send you. These are very concise and are concised accordingly. We'll start with the cell wall inhibitors, the mind map, then protein synthesis inhibitors, then we'll go to anti-metabolites, cell membrane inhibitors and DNA inhibitors, right? And then we'll see some miscellaneous concepts, and if possible we'll have discussion on antifungals, antitubercular, anti-leprosy drugs as well, right? And antivirals as well. Okay, starting with this, let's start with the very first, cell wall inhibitors. So a bacteria has cell wall, right? If it is a bacteria, then a cell wall is always there. So there are two ways of killing a bacteria. To kill a bacteria, there are two ways. One is called bactericidal, and second way to prevent an infection, bacterial infection, is bactericidal or bactericidal and bacteriostatic. So we have antibiotics or we have cell wall inhibitors. Accordingly, we can have cidal ones or static ones, right? All are static except Bevaffa. This is BE, that is beta lactams. VA is vancomycin. F is fluoroquinolones. A is aminoglycosides, right? Beta lactams, vancomycin, fluoroquinolone and aminoglycosides are bactericidal. Okay, and rest all are bacteriostatic. So cell wall inhibitors, how to remember? You can remember the mnemonic: firmly bind to bacterial cell wall. Okay, I'm not writing wall, I'm writing wall, sounding like that, sounding like wall. Firmly binding to bacterial cell wall. So firmly, F is phosphomycin, which you don't need to read. B is beta lactams, which is a major topic and a long question for you. Sorry. Next B is bacitracin. Okay, bacitracin is basically a cream for bacillus, obtained from Bacillus subtilis, and it is used in soft tissue infection caused by streptococcus, strep or staphylococcus. Okay, soft tissue infection, Bacillus subtilis is the source, and it is nephrotoxic. Okay, three important points. C is cycloserine. Okay, cycloserine, not cephalosporin, cycloserine. And V is vancomycin. Vancomycin and teicoplanin, I can club it together. Okay, these are glycopeptides. So vancomycin and teicoplanin are glycopeptides. I can club them together, right? So let's start. Beta lactams. So beta lactams, always when you say we have something like this: carbon atoms 3 in number, then nitrogen is there, and this group is there. Okay, and here a side ring is always there, a side ring, and a side ring is the cause of allergy. Okay, so whenever you have drug allergies, as far beta lactams are concerned, you have allergy due to the side ring only. If the side ring is absent, we have no allergy. One drug is there, that is called monobactam. Okay, one example, aztreonam. Aztreonam is the drug name which has no allergy. Okay, no allergy. Don't need to remember the use. Used in gram negative infection, don't need to remember. So monobactam, just remember one point: no cross allergy because there is no side ring, right? Okay. So the one of the most important beta lactams is penicillin. So beta lactams you can classify in 4 groups: penicillin, monobactams, cephalosporin and carbapenem. Okay, 4 groups of beta lactams. So beta lactams or beta lactams antibodies, 4 groups: penicillin, monobactam, cephalosporin, carbapenem. Penicillin, the original penicillin, the first developed penicillin was penicillin G or benzyl penicillin, right? This penicillin G or benzyl penicillin is the first developed penicillin, which is acid labile, that is degraded by acid, short acting, Narrow spectrum means it is beneficial against some common microbes only, not against all. Resistance is there and allergy is there. All types of allergy, type 1, type 2, type 3, type 4, all type of hypersensitivity reaction is caused by penicillin G, right? And for this allergy you can give azithromycin for this allergy. Okay. This penicillin G is the drug of choice. And this penicillin G is the drug of choice. And you can remember last man go. Okay. Last man go is the drug of choice. Okay. The diseases in which penicillin G is the drug of choice. Listeria, actinomyces, syphilis, tetanus, meningococcus, anthrax and gonococcus. So 2 cocci are there. Syphilis, tetanus, anthrax, okay, and listeria and actinomyces. Okay. But gonococcus drug of choice is penicillin G. But in gonococcal urethritis, the drug of choice is ceftriaxone plus azithromycin, right? In gonococcal urethritis, drug of choice is ceftriaxone plus azithromycin. In non-gonococcal urethritis, drug of choice is azithromycin. Okay. So last mango is the mnemonic for penicillin G. So we developed, this was acid labile, right? We wanted to make acid resistant. So we made acid resistant penicillins. You can remember vodka. B is penicillin B. O is oxacillin. D is dicloxacillin. C is cloxacillin. A is ampicillin and amoxicillin. Right? Very easy to remember. So penicillin V, oxacillin, dicloxacillin, cloxacillin and ampicillin or amoxicillin. These are the acid resistant penicillins. Right? Okay. Then we developed, it was short acting, right? Second problem, it was short acting, original one. So we developed long acting penicillins. So long acting penicillins, we combined penicillin with probenecid. Probenecid basically competes with the tubular pumps. Okay, competes with penicillin at the tubular pumps and has its action. Okay, so 2 long acting penicillins are there, benzathine penicillin and procaine penicillin, right? One which was commonly used, penicillin G plus probenecid. So they ask you what is the use of probenecid. Probenecid makes the penicillin longer acting. Makes the penicillin longer acting, right? Benzathine penicillin is the longest penicillin, okay, and procaine penicillin. Some important points about benzathine penicillin. It is the drug of choice for prophylaxis of rheumatic fever, okay. So when you have rheumatic fever, benzathine penicillin is the drug of choice. You give 1.2 million international unit IM once a month into 6 months, okay. You give 1.2 million international unit once a month into 6 months, right? So this is given 6 monthly for the prophylaxis of rheumatic fever, not the treatment, prophylaxis. And also it is the drug of choice for syphilis, okay. Now see, drug of choice of syphilis was penicillin G, right? I told you, but now it has been changed to this long acting penicillin. It's the longest acting penicillin, and this longest acting penicillin is the benzathine penicillin, right? So syphilis, you know, has 4-5 stages: primary syphilis, secondary, early latent, late latent, and tertiary syphilis, right? So in primary, secondary, and early latent syphilis, you give 2.4 million international unit IM once, only single dose. Up to early latent stage, we give 2.4 million IU single dose. But in late latent and tertiary syphilis, we give 2.4 million international unit IM once a week into 3 weeks. Okay. So I told you the primary, secondary, early latent, late latent and tertiary. In primary and secondary and early latent, we give 2.4 million IU IM once, single dose. But in late latent and tertiary syphilis, we give 2.4 million international unit IM once a week into 3 weeks, right? So you have to remember the dose for this. In neurosyphilis, you cannot use this. In neurosyphilis, you can use aqueous penicillin. Aqueous penicillin is basically procaine penicillin and penicillin G plus probenecid. So this procaine penicillin and penicillin G plus probenecid, this is called as aqueous penicillin, and this aqueous penicillin is given in neurosyphilis. Okay, don't need to remember the dose, just know aqueous penicillin is given. Allergy in syphilis is called as Jarris-Herxheimer reaction. If you want, you can remember, but no need to. But they don't ask you usually. Jarris-Herxheimer reaction is the use in the allergy in syphilis. Then it was narrow spectrum. So let's make it extended spectrum. So extended spectrum penicillin, we have 3: aminopenicillin, carboxypenicillin, and uridopenicillin. Okay. So we have 3 groups: amino, carboxy, and urido. Aminopenicillin, we have 2 examples: ampicillin and amoxicillin. Okay, effective against E. coli only. It is effective against E. coli only, not against Pseudomonas or Klebsiella. Carboxypenicillin, we have carbamazepine and ticarcillin. Effective against E. coli and Pseudomonas, not against Klebsiella. Only penicillin that acts against all E. coli, Pseudomonas, and Klebsiella is uridopenicillin. Uridopenicillin, we have 3 examples: meslocillin, azlocillin, and piperacillin. Okay. So amino, ampicillin, amoxicillin; carboxy, carbamazepine, ticarcillin; urido, meslo, azlo, piperacillin. Okay. So ampicillin is the drug of choice in Listeria meningitis, and also the drug of choice for Enterococcus faecalis. This is less important. Listeria meningitis you must know. So Listeria, you know about Listeria, the tumbling bacteria. Listeriosis was the disease, and it also has meningitis. So Listeria monocytogenes, Listeria meningitis, ampicillin is used, right? It is excreted in bile. Okay. Amoxicillin is used in Streptococcus pneumonia. Okay. And it is less excreted in bile. Which has the maximum oral bioavailability? Amoxicillin. So it is very commonly used, right? Okay. Then some bacteria are prone to produce penicillinase. Due to which penicillins were not working, right? Because they were degrading the penicillins. So we made some penicillinase resistant penicillins: cloxacillin, oxacillin, nafcillin, dicloxacillin, and methicillin. Cloxacillin, oxacillin, nafcillin, dicloxacillin, and methicillin. Methicillin is M for M, most resistant. Okay, most resistant. Done. Okay. So with that we come to the end of penicillins. Let's start with monobactams. I told you one example, Aztreonam, no cross allergy. Let's start with cephalosporin. Cephalosporin is a wide range of drugs. We have 5 generations of cephalosporin. Okay, very easy to remember. First generation, gram positive. Any gram positive bacteria you give, first generation. Second generation, against bacteroids. Third and fourth generation, primarily gram negative infections. And fifth generation is effective against MRSA. What is MRSA? Methicillin resistant Staphylococcus aureus, right? So 5 generations. Just focus on the names. First generation, you have to remember, it is used in drug surgical prophylaxis. That is in before a surgery. We give prophylaxis for preventing infections, which is we give first generation. 2 examples to remember: cephalexin and cefadroxil. Lexin and droxil are first generation, cephalexin and cefadroxil. Second generation, we can have cefaclor and cefuroxime. Okay, chlor and oxime. So 2 examples here, chlor and oxime. but you can remember cefaclor only. Then you can remember MTX, that is cefomandol, M for mandol, cefotitan, and cefoxitin, X for cefoxitin. So MTX you can remember cefomandol, cefotitan, cefoxitin. These three are also important because they cause disulfiram like reaction. Which we'll discuss in CNS in the alcohol chapter. So cefomandol, cefotitan and cefoxitin cause disulfiram like reaction and are second generation. Third generation against gram negative. It is a drug of choice for community acquired gram negative bacteria. Community acquired, right? Not important to remember. Cefixime. Okay, the common drugs which you use are the third generation ones. Most commonly used. Cefixime. Who doesn't know? Cefixime. Cefpodoxime. Ceftriaxone. Okay, these are common drugs. So the common drugs which you commonly hear put in third generation. Two drugs I want to tell you which has Z in their name. Z. Ceftazidime and cefoperazone. Ceftazidime and cefoperazone. If you are preparing for competitive exams like NEET, PG and INI-CT, you just look for Z in their name. Okay. In this Z you can remember these are anti-pseudomonals. So which penicillins are anti-pseudomonal penicillins? Anti-pseudomonas, ceftazidime and cefoperazone. Cefoperazone, very important lines. Cefo, P-E-R-A, right? E-R-A, Z-O-N-E. Cefoperazone, E-R-A. So E and R and A. E stand for excess bleeding. So this drug causes excess bleeding. R is renal safe. You can give easily in kidney patient. A is alcoholics. So you should avoid this in alcoholics. So cefoperazone, three important points. It can cause excess bleeding. It is renal safe but avoided in alcoholics. Okay. In epilepsy and encephalopathy, you give cefepime. Cefepime is a fourth generation drug. So fourth generation, two drugs to remember which have P in their name. P in their name. Cefepime and cefepirone. Okay. Cefepime and cefepirone. These are also anti-pseudomonas. Okay. They ask you MCQ, most effective anti-pseudomonas. So you can answer ceftazidime. Okay. And epilepsy and encephalopathy, cefepime. Fifth generation, you can remember ROL. ROL is always in their name. Effective against MRSA. So ceftaroline and ceftabiprole. Ceftaroline and ceftabiprole. Okay, ROL is always ceftaroline and ceftabiprole. Okay. So with that we come to the end of cephalosporins. Let's talk about carbapenem. Carbapenem is a drug of choice in ESBL producing gram negative bacteria. ESBL producing, that is extended spectrum beta lactamase producing gram negative bacteria. Okay, ESBL producing. So it is a drug of choice. You will always find penem, carbapenem, right? So penem is always in the name. Imipenem, doripenem, meropenem, ertapenem, ferropenem. Okay, imipenem, dori, mero, ertafaro. Imi, dori, mero, ertafaro. Okay, imipenem, doripenem, meropenem, ertapenem, ferropenem. Ferropenem is an oral drug, only oral drug, and imi, dori, meta, mero, erta are IV drugs. But let's say a bacteria becomes carbapenem resistant. remember, whenever a bacteria are becoming more and more resistant, we were using penicillin G. It became resistant and produced penicillinase. It became resistant and produced penicillinase. We gave penicillinase resistant penicillins. I'm sure you must be remembering the name penicillinase resistant. Cloxacillin, oxacillin, dicloxacillin, nafacillin. Okay. Penicillinase resistant penicillins. Again, they produce some other, and we call them ESBL, extended spectrum beta lactamase resistant. So we were giving carbapenem. Now they are becoming carbapenem resistant. Carbapenem resistant. Okay. So the drug of last resort, that is the last used drug used in carbapenem resistant bacteria, are colistin and tigecycline. Colistin and tigecycline. Okay. Colistin and tigecycline. Imipenem, remember an important question. Imipenem is the most toxic carbapenem. It can cause seizures, it can cause kidney damage. So it is combined with cilastatin. Cilastatin makes it less toxic. Okay. We have something called metallo-beta lactamase producing enterobacteriaceae. You know about the enterobacteriaceae family, right? E. coli, Klebsiella, all are enterobacteria. So metallo-beta lactamase producing enterobacteriaceae. We have one famous example, that is NDM. NDM is New Delhi metallolactamase producing enterobacteria, that is called Delhi superbug. And we are using ceftazidime plus avibactam. Ceftazidime for avibactam combination for this. Carbapenem resistant, I talked to. Carbapenem resistant, where we are using colistin and tigecycline. Acinetobacter. Carbapenem resistant Acinetobacter. CRAB. We say it CRAB. CRAB is carbapenem resistant Acinetobacter. Carbapenem resistant Klebsiella, CRKP, and carbapenem resistant Pseudomonas, CRPA. So CRAB, CRKP and CRPA, we use colistin and tigecycline. But in NDM1, New Delhi superbug, you can very well use ceftazidime and avibactam. Okay. So this carbapenems is also done. Cycloserine is used in the treatment of MDR TB. MDR means multi-drug resistant TB, which we will discuss in the TB lecture. Multi-drug resistant TB, you can use cycloserine. Vancomycin and teicoplanin are not oral drug. Sorry. Vancomycin, a very specific side effect, a very special side effect which they commonly ask you. Vanco is the red man syndrome. Red man syndrome. They always ask you red man syndrome. What is the cause of red man syndrome? If you give vancomycin as a IV drug, if you give fast IV, you push the injection fast, then it will degranulate the mast cells. These mast cells are there, they are degranulated. They break and release histamine. So vancomycin basically degranulates the mast cell, releasing histamine, and causes red man syndrome. This histamine is a vasoconstrictor, you know this, right? So it will constrict and cause stasis and cause red man syndrome. It can cause flushing, okay, and red man syndrome. So vancomycin, teicoplanin, we call it glycopeptides. Teicoplanin has no risk of red man. Common drugs are otirvancin, dalvancin, telvancin. Okay, teicoplanin, otirvancin, dalvancin, telvancin. Not important to remember. If you can remember. Right? Vancomycin attached to D-alanine group. Okay. So whenever a bacteria is there in its cell wall, we have D-alanine and D-alanine combination, and vancomycin basically goes and attaches here and destroys this. So it is basically a cell wall destructor, right? But bacteria is very clever. It will change this D-alanine group to D-alanine D-lactose. Okay, it will change its configuration from D-alanine to D-lactose. So now it is also vancomycin resistant. Okay, it is called VRSA. So MRSA, remember MRSA, methicillin resistant staph aureus, we give vancomycin. If it becomes vancomycin resistant, we call it VRSA, and the drug of choice for VRSA is linezolid. Then if it becomes linezolid resistant, we call it LRSA, and the drug of choice for LRSA is streptogramin and drugs like daptomycin, all this. Okay, streptogramin, remember. Okay, vancomycin, where it is used, MRSA, it is also used in MRE, that is methicillin resistant enterococci, and it also given in TSST, that is toxic shock syndrome. Okay, producing toxic shock syndrome toxin, also given TSST, not much important. You just remember MRSA and MRE. Oral vancomycin, where it is given only in one condition, where oral is given, oral vancomycin is given in pseudomembranous colitis. Pseudomembranous colitis, you know, is caused by Clostridium difficile. Okay, pseudomembranous colitis. So it is given oral. Right? Okay. For ESBL producing Enterobacteriaceae, for treatment of ESBL producing Enterobacteriaceae, okay, we have beta-lactamase inhibitors. What we do is to combine this beta-lactamase and beta-lactam antibodies with beta-lactamase inhibitors, so that the bacteria can be killed very easily, right? So treatment of ESBL producing Enterobacteriaceae, what we do, we combine the antibiotic is combined with beta-lactamase inhibitors. We combine amoxicillin with clavulanic acid. We combine ampicillin with sulbactam, piperacillin with tazobactam, and avibactam is also there. We combine avibactam plus ceftazidime. Where it was used, avibactam plus ceftazidime in treatment of NDM superbug. Remember, NDM superbug, we talked about avibactam plus ceftazidime. Amoxiclav is a common combination, amoxicillin clavulanic acid, very rampantly used. Sulbactam, ampicillin, tazobactam, piperacillin. Sulbactam, ampicillin, tazobactam, piperacillin. So they can ask you these combinations as well, right? With this, come to the end of today's lecture. I am not doing good, so we'll continue from cell protein synthesis inhibitors from the next lecture. Okay, and this lecture is all about cell wall inhibitors, which I am sure you must be understanding all of this. And in your MB, about 10 marks is coming from this 30 minutes. Okay, from this 30-minute lecture, about 10 marks is for sure. You can take it from written from me. 10 marks is sure from this 30 minutes. So just revise this lecture again and again. Revise this mind map, and they may ask you what are the probable questions. So penicillin is a long question, uses and all. Then cephalosporin is a very famous long question. They will ask you classification. Beta-lactamase antibodies, beta-lactamase inhibitors are very important. They ask you the uses of penicillin. They ask you the types of penicillin. They ask you acid resistant, long acting, extended, all of this. Ask you about the cephalosporin classification. Very important. First generation lexindroxil. Second, chlor, MTX, mandoltetan and zictin. Third generation, all of the common, cefixime, cefodoxime, ceftriaxone, and ceftazidime, cefoperazone, Z1s. Fourth generation, 2, cefepime, cefepirone. Fifth generation role, ceftarolin, ceftabiprole. You can use the classification again and again and tell all the examples so that you can remember it. Okay, with this we come to the end of lecture. We'll continue from the next class. Thank you and thanks for watching.